Throughout my professional journey, I have always prioritized the health and well-being of the patient. So I'd like to share with you experiences that demonstrate the benefits of visualized endometrial sampling over blind curettage or biopsy. In this example, we'll take a look at a case that illustrates the benefits of visualized sampling to provide the opportunity to detect focal pathology. This patient is a 59-year-old who we were consulted on for incidentally found thickened endometrium. She actually was admitted to the medicine service as an inpatient for an MS flare. And during that workup, they did a CT abdomen and pelvis, which showed an incidentally thickened endometrium. So we requested an ultrasound, and that did confirm that the endometrial lining was 18 millimeters and had cystic areas. There were no discrete endometrial lesions seen on the ultrasound, so we opted to do an endometrial biopsy in the hospital bed, given that she was admitted for more concerning issues. That endometrial biopsy did come back as benign. She had strips of benign endometrial tissue and benign endocervical tissue. However, given that she was very high risk, being postmenopausal, we opted to continue to think about this case. And in looking at the ultrasound, it became very clear to me that there was a discrepancy between the biopsy and the ultrasound results. The biopsy really was clearly benign, but the ultrasound did look concerning to me. So I did talk to the patient again about further evaluation, and we opted to proceed with a hysteroscopy for visualized endometrial sampling. So in this case, you can see that clearly upon introduction of the hysteroscope, there is a very large focal lesion, and that was causing the ultrasound findings and the CT findings of that thickened endometrium. This is a large focal lesion, so obviously can be confused for a diffusely thickened endometrium, and it was not seen as a discrete mass on her ultrasound or her CT scan. But fortunately, looking at the ultrasound really wasn't concordant with the endometrial biopsy. And when I have a case where the biopsy is not concordant with the clinical picture, I do think the gold standard for diagnosis is doing that hysteroscopy to give the patient, and honestly ourselves, the peace of mind that we have not missed a focal lesion. So this case is a perfect example of how we could have missed a focal lesion that ended up being, unfortunately for this patient, carcinoma. But fortunately for her, we were able to make that diagnosis early. And because we were able to do this hysteroscopy while she was an inpatient, get her to treatment in a very prompt and expeditious manner. So you can see here with the hysteroscope, we're able to remove the entire lesion, send it to pathology where there's no artifact, and they're able to analyze all of that tissue and give this patient a very accurate diagnosis. So in summary, this is a great case to show how hysteroscopy is really the gold standard for diagnosing these focal lesions.